Welcome to the 2025 Sick Kids National Pain Awareness Week speaker series. Thank you so much for joining us today. My name's Ashley Harvey, and I'm one of the clinical nurse specialists with the acute pain service here at Sick Kids, and I'll be the moderator for the session today. Today's session is going to be recorded, so we do ask that throughout the conversation, just not to bring up any confidential patient information. This will be quite informal, so feel free to put any questions in the chat throughout the conversation. Also, feel free to raise your hand sort of in the middle of everything, because we do want to keep things dynamic, and we're hoping that folks are engaged and have perhaps come with some of their own patient examples that we can sort of pick the brains of our experts on. I do want to mention that this session will be available for viewing on the Sick Kids Pain Center YouTube channel. So you can also check out recordings from last year's speaker series that are already posted online, some of which are shown here in a screenshot on the slide that you are seeing. We're also interested to know who's joining our session today. So if you are comfortable, we'd love for you to introduce yourself in the chat. Maybe let us know what your role is and if you're from Sick Kids or from outside of Sick Kids. Our virtual speaker series session today is going to be focusing on setting appropriate expectations of pain for patients and their families. And it's my pleasure to introduce our speakers for today, Caleb Tait and Dr. David Levine. Caleb has served as a child life specialist at the Hospital for Sick Children since 2017. He currently works in procedurally intensive areas including phlebotomy, POCU, and helps support procedures across the hospital. Guided by a commitment to equity and patient-centered care, Caleb ensures that children and families experience surgical and procedural environments with dignity, understanding, and emotional safety. He is a consistent and calming presence, often accompanying patients through challenging procedures and fostering trust among families and clinical teams. Caleb's expertise in supporting behaviorally and developmentally complex pediatric patients has been recognized within the Sick Kids President's Award in both 2020 and 2023. He contributes actively to the institutional initiatives and has presented at national forums including Project ECHO and the ACLP. His recent presentation, Doing Tough Things the Right Way, explored adaptive child life strategies for outpatient settings at the 2025 ACLP Child Life Conference. Through his clinical practice and advocacy, Caleb exemplifies excellence, empathy, and innovation in pediatric psychosocial care. And I will just add from a personal experience and knowing all of the people who work with Caleb throughout perioperative services, he is an asset to this organization and we love him very much. Dr. Dave Levine is an anesthesiologist here at Sick Kids and assistant professor in the Department of Anesthesiology and Pain Medicine at the University of Toronto. He also works in the Transitional Pain Clinic here at Sick Kids, where he's a part of an interdisciplinary team offering support for patients throughout their perioperative journey. I'm going to stop with the introductions there. I'm going to kind of move on to our title slide and allow Caleb and Dave to take it away.
Hello, everyone. I'm Caleb.
Nice to meet you. I'm David.
Today, we're going to be talking about setting appropriate expectations of pain for patients and families. This is a very informal presentation. We want it to be more a discussion and a focus on the practical side of things. If there's anything that you want to bring up, feel free. Please don't hesitate. We have what we are planning to talk about today, but with that, we want to be flexible and adaptable as we think of more things as things come up, but also if there's anything coming from the group here. But we want to look at the importance of being upfront, honest, and age-appropriate with patients and families when it comes to talking about what to expect with pain, with discomfort in a medical setting. We're going to talk about this both in a procedural side because we're doing something right now that might be painful or difficult. Post-procedural pain, we can talk about the chronic side of pain and any type of those conversations that can come in between that. So what to expect, the pros of appropriately having these conversations, but also the negative outcomes if we don't handle them in an appropriate way for the patients and families that we serve.
Caleb asked me if I would help participate in this presentation. I think because Caleb and I have worked together with challenging patients and their families several times. And I think both appreciate each other's way of managing these situations. And I think because of that, we thought if we were together, we could share our experience and our stories in a way that's been really collaborative. And I say Caleb, and I really mean all of the child life specialists in peri-op. I know what patients experience sort of pre-op and a little bit post-op. And I'd love to learn through this also what you see on the wards or as families get home and then come back as outpatients to find out if our job of setting expectations matches what you see and what else we can be doing in the brief time that we have with patients to do better for them.
I want to start by setting the stage with, I used to work at a summer camp and we had this kind of prank that we would do at the start and it involved expectations, and I think it can help set the stage for what we're going to talk about today. But this would be something we would do with the kids, but when we had parents or counselors. At the start, we would ask of the adults there who knew milk the best. We would have someone come up and they would be blindfolded and they were going to try all of these different glasses of milk to see if they knew which one it could be. You were going to drink it, is it 2%? Is it soy? Is it skim? Is it chocolate? And they'd go through and they'd be guessing and everyone's clapping along, but what they didn't realize was near the end of the line of the different milks was a glass of orange juice. You're going in, you're expecting milk, you take a swig and it's pulpy orange juice and they would spit it out. It would be disgusting. It would be gross. And just by setting expectations, something that isn't even hard. Drinking a glass of orange juice is not difficult. But when you're expecting something else and you're caught off guard and it's not what you're expecting, something that's easy can become quite difficult and quite distressing. The reason I want to bring up that example is we're talking about pain and discomfort in a medical setting, which is objectively a difficult thing. So if improper expectations can cause distress for an easy thing, it's just magnified when it's talking about something that is objectively difficult. We want to talk about what we can do to help properly set those expectations. We're going to talk about the role of those communications, recognize and discuss all of the different contexts in which these can take place. We're going to discuss examples that we have, but we are so open to discussing examples that you may want to discuss. We're also going to talk about the common hesitations and barriers that, as healthcare providers, as caregivers for children, people are coming here where they're doing it from the healthcare side, but it may be for their own children or people in their own lives as well. The hesitations that may come there, and giving strategies to take those steps forward. We also want to talk about giving yourself grace in those conversations. It's not that it has to be a perfect conversation, it's that we're taking the approaches and we're giving the best chance we can for patients, for families, for everyone involved to understand and work together to take a collaborative approach to help these patients through difficult things. We know that by properly setting these expectations, we do our best to facilitate preparation, informed decision-making, coping. A huge one is trust, as well as proper medical care and treatment, making sure that we're following patient and family-centered care as well as trauma-informed care. And we're trying to avoid things like undue stress or trauma. We know that things are hard here, but we don't want to add extras to make sure we don't create a mistrust with medical systems or within families, from the patients themselves, from the families as a whole. We don't want to delay or avoid medical care as we go into the future, and also just incomplete medical care. So as we talk through this, we're going to have lots of bits and pieces where we put in, so we're going to be jumping around a little, but we'll try our best to follow through with a bit of a thought process. And I think the one we wanted to start with was kind of procedural pain or acute pain, like we're doing a painful thing right now. One of the easiest examples of that is a needle. It's kind of the most clear-cut example. There's lots and lots of different things that can be fit in this, going to do something right now, and it may be painful or uncomfortable. I think one of the biggest things that you will see there from our coworkers, from parents, is like, this isn't going to hurt. There's lots of things, if we tell someone something's not going to hurt when it will, there's lots of things that can go south from there. The first one I think of is someone who works in blood work is, if we tell you it's not going to hurt, you're going to move. Because if that feeling comes up and you're not expecting something, you're going to move. It may hurt more because we move, but we also might have more pulse. And even within that, there's anger, there's upset, there's a loss of trust with whoever told them it wasn't going to hurt, whether that's us, whether it's a caregiver, because it's fair for things to be hard, but we don't want to add that extra. And if we tell you something's not going to hurt and it does, not only was that thing that may have been difficult, now you're not going to believe us if we tell you something else that isn't going to hurt. If you told me this wasn't going to hurt, we're going to do a poke and it's a butterfly. And the next thing we tell you that actually should be painless or not stressful. Yeah, right. You said that last time and then you poked me with a sharp thing. We want to make sure that we're being honest. I think some people can feel worried about upsetting people when they talk about those types of things, but it's also appropriate for kids to be upset for these hard things. And we want to manage those expectations and what we can do to help. I think we get to frame the experience when we get ahead of the game. We want to kind of put it that way. There's that pinch. We get to use a word that can fit everyone. A blood work does feel like a pinch. Some people may have bigger reactions to a pinch or smaller or different expectations, but it's a good place to start. I think one of the things that you can speak to as well is people perceive pain differently, but it doesn't mean that we're going to say, the last person, it didn't bother them. We're here, but being able to frame it and where they can understand it in the way that's going to suit them best.
And the IV start is a great example, at least for somebody who works in the perioperative environment, because is your first intervention with the patient often before they go for what's generally a larger intervention. And so if you can build the trust and manage expectations for the first encounter, I think you can shape the next encounter. It's a particularly salient example. And obviously needle pokes happen outside of the perioperative context, but within that context, if you can set the appropriate expectations, move them through that where you meet their expectations, you then have trust with you and with the rest of the healthcare team for the rest of their journey. And something that we think about a lot, I'm sure we all think about a lot, is the patients that are coming for a one-off procedure versus the patients that will come back for multiple procedures, and how the expectation setting for yourself and for the family can be different, because if it's a one-off and they're young and they might not come back to the hospital for 5 years and they may not remember, if things don't go perfectly, there's less lost. Not that we don't want it to go perfectly every time, but the patient who's coming back in a few weeks for another test, if you mess up that interaction early, it can really create much more friction for each ongoing visit. Sometimes you really have to work a lot harder the next time for families that have had that mismatch of expectation.
I think sometimes people think if we don't set those expectations or we lie or don't tell a full truth, I think that can sometimes make it easier. Yeah. And I think that's the difference. We can get to the chair in blood work. We can get up to the step where we're going to do that hard thing because we don't know what to expect. That doesn't always help once, but it never helps more than once. And I think it's being able to create that trust and maintain it, but it also helps as care providers. Not only are we helping the family and the patient be prepared, but as care providers, we're there. If we know that someone has difficulty staying still or they get really worked up in something, if we're honest about what these difficult points may be, we're able to help make sure that we're in place to provide the appropriate support for them. It can help us assess how a patient will handle the situation. It can help identify what their stressors may be. It's not always pain that's the biggest stressor either. And by putting these things in place and framing them, we get to make the plan that works for them. But as healthcare providers, we can ensure that we're set up to provide the support that they need. And that's both in this acute procedural context that we're going to talk about, as well as the post-operative side of things. We can know whether a plan is feasible for a patient. In blood work, I often get someone who's like, and do you want to sit with someone or alone? And it's a kid who can't sit on their own when we're not doing something. That's painful. So it's not a feasible plan, but then being able to frame that we are going to have someone that you get to sit with and give you a hug. So even if you're scared or even if something hard, you're safe and we're here to take care of you. Talking about pinch for a blood work and then adding in and then we put a Band-Aid on after. It's those little cues that maybe aren't, hey, we're going to poke you with a sharp thing. That's not what we're saying when talking about pain, but there's going to be a pinch feeling. We'll have that hug so you stay still and you stay safe. And when it's all done, we press on the spot and we put a Band-Aid. It lets the child know what to expect in a way that suits them well. Ideally, in a way that they can understand, because kids know a Band-Aid equals, I had a cut, I had something I had to cover up, and a Band-Aid is something that helps. Or they don't like one, at which point, that your plan isn't to put a Band-Aid on at the end. I think lots of times too, there's parents who may come in quite nervous and anxious, and we offer something that can help manage pain. It gets treated as this solve all. And I think cold spray, the painies is a big one for that. The amount of times in blood work, I've said, and we have a cold spray that can help numb it. And the parent goes straight to, so you won't feel it at all. That is so different from, we have a cold spray that's like putting an ice pack on first. And you get to say, so most kids know an ice pack. You can try and put it to an experience they've had. Have you ever bonked your knee, stubbed your toe? You put an ice pack on to help it feel a little bit better. This is an ice pack we can put on first because we have the benefit of knowing where we're going to have the ouch. You don't know you're going to stub your toe and you can't put an ice pack on first, but today we can do that. Or talking about cream, it's going to change it from you don't feel the pinch, you still feel pressure. You still know you have a hand, you have that spot, but it's to take away the pinch part. So it's to frame it there, and a lot of that ability to get ahead of the game and talk about what might be hard also allows us to talk about what we're doing to help with. And I think that part of that is we get to know what those appropriate things will be for the patient, but also the patient gets to see what we're doing for them instead of just to them. And it gets to frame that whole experience while still being upfront and honest about what the hard parts of that are going to be. It helps us know how to position. Where is the best support? Is this something that we can do? So is this our huge stressor? Because for some kids, it may be that painful thing and it may not. We always treat pain in our head as we want to minimize it as much as possible, which is, very true. but also what might be upsetting isn't the poke. It might be the in prep going into the room with everything happening. Being upfront with pain helps us manage the pain, but also know if that's the biggest worry right now.
Question I like to ask is always, especially for patients that might have been at the hospital or undergoing anesthesia previously, is how did things go last time? Was there anything about the experience that was positive or negative? And 90% of the time they say, oh, everything went great. But sometimes they'll tell you specifically they woke up nauseated, or the IV was a challenge, or they really didn't like the mask. And at that point, you can specifically address the thing that was the most concerning, make the focus about how you're going to remediate that aspect of the care. And I find when you acknowledge and address something that didn't go well, that can really alleviate the stress as well. A similar question can be for children who haven't had the experience of an anesthetic. When was the last time you had a cut or a scrape or needed a Band-Aid? And then you can frame the needle poke as similar or a little bit easier than that. This is a mundane thing that's part of a normal life, so this is going to be something you wouldn't choose to do unless it was medically necessary, but you'll survive. I think getting the patient and the family's feedback on their reference for their experience can really help you choose where to focus the expectation setting.
Absolutely. And those expectations can be the pain itself, or even sometimes the amount of time that that's going to last. For something like an injection, sometimes it's the poke itself, but then the medication is harder. Or it's those little things where I know for myself, I'm so much more dramatic for an annoying amount of pain than I am for a bigger amount. If something is like big, it's that like take the breath and get through, but that annoying, nagging pain, those types of things. Everyone's going to have those things that might be easier or harder for them, and being able to talk through honestly sets those expectations, but also gets your perception of where they're at. I think sometimes we feel worried about putting forward a specific word. It's pain, it's surgery, it's this. When NG tube, if someone asks if it hurts, it might be more uncomfortable. You might not say ouch, but you're not going to like it. It's a weird feeling. It's this. And getting to frame what those perceptions are going to be across can really make a big difference and build all of those positive things that we've talked about and do our best to avoid those things as well. There's lots of examples of these types of things that we're doing in the moment, but we're also going to spend some time talking about the post-operative pain, because that's a huge worry and concern that people have for surgery. Sometimes people have the worry of pain during, and we have an anesthesiologist. The during pain is really easy. It's really easy to get that fear taken away of. You have someone whose whole job is to make sure that you don't feel something while it's happening, but it's that after side that we want to make sure we can manage those expectations while managing the pain as well. I think you do a great job of having that conversation where it's setting the tone of not sugarcoating, not catastrophizing, but here's what we're doing, here's what you're looking for, here's what things should be like after. I think that's one of the things that I've heard lots, and hearing different people handle those differently, you get to see where it sets families up for a lot more success afterward. You know, that anxiety of the unknown, unknown can be such a scary thing. Pain and anxiety can go together so much. I think there's a level of nervousness, anxiety that goes before these things that is an appropriate level to have. By adding in like the unknown or that trick or that being less clear adds that undue stress, which has all of these different outcomes that can come.
In addition to setting expectations fairly, so I think healthcare providers sometimes are hesitant to say that there will be pain after procedure, there will be nausea, there will be symptoms that are uncomfortable. I think to explain the possibility of the symptom, then also that there's an appropriate measure that will be taken in the presence of those symptoms, also alleviates that anxiety and the fear. To say some children, we give you medication that's meant to let you wake up fairly comfortable. But if you are more uncomfortable than you can cope with, very quickly, you're going to be offered a pain medication that's given through this IV and works quickly. Then they know that even in a worst case scenario where things are worse than they were expecting, there's a management plan that addresses that specifically. Caleb and I have talked about this idea of sort of narrative versions of the outcome. So we have like a really good outcome where some patients wake up and they're really not that uncomfortable. Some are a little bit more uncomfortable, and this is the pathway that we open up in that case. These are the teams that we can invite and the measures that we can take, and that we're aware of them and paying attention to them. And I think that really helps as well.
I'm a child life specialist that works in peri-op, where we have 16 rooms that operate every day, all throughout the day. I don't always know what the expected outcome of pain is. So I have my general spiel that I put forward that, like, if that's good enough for you, let's leave it there because I know it's true. If we need to find more information beyond that, the idea of, while you're asleep, you have medicine so you don't feel anything. And the doctors and nurses give you medication to help you feel waking as comfortable as you can. But you also have a nurse whose first question when you wake up is, how are you feeling? Does something hurt? Can I help? For a vast majority of patients and families, that is enough, knowing at each step you have that person watching, carrying them. But for the ones who it's not, we can go find those answers as well. I don't have them. I don't know the ins and outs of everything, but being able to start with a general information that is true, that we can count on that being true, but then being able to take those steps forward as we go. Because I think with that hesitation for people to have that conversation is like, well, I don't know exactly. And with perceptions of pain, no one knows exactly, but you get to frame those in place properly. And it goes back to that, what we can do to help. When you know it's true, you get to build from there. And then whatever happens after, whatever approach we take fits in, and it doesn't lead to that cognitive dissonance of like, that's not what you told me. I think there's so many times where being able to frame something where you say like, and then we put the breathing tube in, and when you wake up, you have a sore throat. But it's the type of sore throat a freezy can help. I had, when I was an intern, there was a patient who was on the spectrum and was going in for an appendix. He was told, you're going to go in because it hurts. They're going to do surgery and it won't hurt anymore. And he woke up and he wasn't even upset, but he was confused and saying like, well, it still hurts. So then being able to explain, well, that's the appendix isn't hurting more. It's the small incisions that we did in this amount of time is what we're going to do to help it, and the freezing and those types of things. Because if you're told something's not going to hurt, a procedure, and you wake up and it does, either you're like, you lied to me, or you think something went wrong. And I've had some patients who are nonverbal or anything, and the family was told this procedure wasn't going to hurt at all. And the patient woke up quite upset. And when you don't, now we're confused. Did something go wrong? What's happening? Whereas opposed to being set up for success afterwards. It is uncomfortable. If you want to avoid a loaded word for a family, for a child, can we still make sure that what we're saying is true? Because we want to make sure with what we say before matches up with what happens, which can be hard for people because sometimes saying before, if that thing is unpleasant, it's hard to bring that up. But if the unpleasant point is unavoidable, you're just delaying the hard part. And it means when we get there, no one is ready for it. Like, it's just going to make that harder, as opposed to being able to set up, whether that's that someone needs extra help to stay still after. Is this someone who needs to be in a hospital during some of the recovery because it's not something that we can handle at home? To know if it's pain or if it's, is this something where safety becomes an issue? If we don't talk about those and know before, we don't have a plan in place, and then we're trying to figure out in this escalated time what to do. And as someone who's been a part on both sides where we are properly prepared and we are not, they are such different scenarios, and it just has such a different feeling where even if someone's upset and that thing is hard, when we're prepared, when it was fair, when it was put forward, we're still doing right by the people we're taking care of, even through that hard thing.
Yeah, and something I've learned from experience is that the things that parents and children, they wake up from their procedure and they have these feelings that they weren't expecting, and it's not always the thing that we're taught to tell them about. So in anesthesia training, we're taught to talk about sore throat, post-op nausea, and pain. And as an example, after an all-day scoliosis surgery, many children will wake up with a puffy face because they're face down and they receive a fair amount of fluids. And the first thing that parents see is their child has a really swollen face, and the lids will be swollen, and the conjunctiva can be swollen. And immediately it's their child. The child is covered in a blanket, and all they can see is the face, and they're worried that there's an allergic reaction. Is this normal? And so with experience, you learn to frame expectations around even what are relatively benign. So swollen face resolves, the fluid resorbs, it gets better. But now when I counsel parents, I always mention a swollen face. And I think actually when Caleb invited me to this talk, that's part of what I was most interested in is I think I've gotten fairly good at navigating anticipating the problems patients and families will experience and trying to coach them and set expectations in that perioperative environment where I'm in contact with the family. So pre-op, intra-op, and until they leave the PACU. But I'm wondering if you, for anyone on this call, receives patients on the floor or sees them as outpatients, and if they're seeing mismanaged expectations that they have to sort of explain in retrospect. I'd just be very curious to hear from anyone who's in this session what their experience has been.
We want to make sure, I think a big part of that preparation is to alleviate the anxiety before, but also to avoid that that's not what you told me. and seeing if there's those things, even coming from the best of places with the best of intentions. Either something was explained in a way that didn't match up, or left out because it wasn't something you were aware of. Because it's like, I would have talked about that, I just didn't
exactly.
think of it.
We want to know if we're passing the baton
Yeah,
smoothly.
if it's setting everyone up for success, which is everyone involved. It's the patient, it's the family, and it's the staff as you go. But I think that those idea of, you didn't tell me that part, because I would have talked about that. Like, great point. I'm going to make sure next time I bring that up, because this thing that was upsetting for someone I haven't seen before, but it is such a valid thing for someone to be upset or worried about. And we think that it's this idea of pain's the biggest thing, but it can be that fear that something looks different. It's that discomfort and expectations of what we can do after something to help with that pain too. Because that's a big one post-operatively for different procedures, is when you wake up, like, you go into a procedure, you get medical health, you get healthcare because you're like, this is going to help. But there's a road to recovery, and that can be a day, that can be a week, it can be longer. And people may not follow the trajectory that they're thinking or that they're ready for. But being able to have those conversations, you kind of talked about that, like, movement is medicine after some of these things. But it's hard. It hurts. You did this. Now you're asking me to do something that hurts, and it's supposed to make it better. But we also like having those expectations for people to talk them through it, so they know before, during, after, or when do we talk about this thing. Some people like step by step. Okay, if I get to that place, I know I'm with the physiotherapist, the nurses, the doctors who are on the recovery side. Or you're sitting there like, that is the thing I'm thinking about, and I need to know it first. Everyone's different. So by having these upfront conversations, you're talking about what was hard last time, what was here. By putting those forward and creating that discussion, you get to figure out what those possible obstacles are, and either avoiding them if we can avoid them, or approaching them in the right way. Because the thing you're thinking of that I think the kid's going to be most nervous about this, like, it's not a problem.
Yeah.
It's actually, the discomfort. How do I sleep in 5 days after?
It's the Foley catheter.
Yeah. What's this? Is that, that discomfort, that pain? It's not even the procedural part. It's all of these extras. So putting those forward really helps us get to the bottom and take that patient and family-centered care aspect. I had a patient recently who's going for a large surgery who the two questions were, am I going to die, and how do I stretch after? So it's like the full gambit and the full spectrum of that is someone who is thinking through every part of this. It's this huge, big question, but also thinking about, like, I know I'm going to be sore. I know I'm going to be uncomfortable. Not even worried about the, surgical site, the incision. It's the, like, I know I'm going to be stuck in bed and things are going to be harder. They're going to be sore. The amount of kids who get a cast taken off and it's just weird. Maybe it's not pain, it's discomfort. It's weird, it's odd. You're expecting those, but to help shape it, and you never know what's going to be on that person's mind unless you ask them. We have a great place to start as professionals here who work in pediatric, who work in the areas we do. You have your best first guess of what we should talk about, but it's that ability to, like, reassess and work with the patients and families can make that huge difference as we approach, like, every step of this, because there's those things that are in the moment and there's those things that are down the line. And sometimes it's all hard, and sometimes it's one thing or the other, and sometimes it surprises everyone, but we want to give our best chance. I've had some patients who pain was something they weren't worried about. We talked about it. We brought it up. Pain didn't handle it as well as they had expected to. They had their own expectations, but it, caught off guard. We had the chance. We have someone who thinks pain is going to be the number one stressor. And then, oh, that's it. Because you're there and you're prepared. So it doesn't mean that you have these conversations and now we are sunshines and rainbows and there's no problems. It means we are as prepared as possible and working together, and we're doing what we can to take care of it.
Just Ashley put in the chat to invite everyone to please share their own experiences or questions, so would love to hear from you guys.
Yeah.
I can just share Fiona's comment here. She says, Dr. Campbell is recently retired anesthesiologist from the department here at Sick Kids, and was a very long-standing member, medical director of our chronic pain service, among many, many other accolades. She says, loves this conversation about validating fear of pain and what we can do about it on the day. I'm wondering whether you think there is a role for patients and families to learn tips and tricks to manage anxiety prior to the day of surgery. Any thoughts on how we can do this?
I absolutely, this kind of falls in more on the child life and that side of things. I think having resources, whether it's preparation in general coming in, that it's gaining more information about what's going on, or something like the Calm Companion, which is something that we're working on, that isn't a focus on the procedure itself, but it's on the experience of coming in for surgery. So it won't really change depending if you are coming in for scoliosis surgery or anything, but it's as you approach this, here's the things that are available for you to come in that we can provide, but also you can come in ready to know about, to help take care of anxiety. And it's different things will help different people. So by providing lots of different options and seeing what that right fit is, even I'm sure when you have that conversation, you get to know if this is a patient we are talking about every nitty gritty thing with, or this is a patient that we are just talking about the most important things in what we're doing to help. And that's the same from a very medical sense, from that, more black and white medical information versus some of that gray area of anxiety management of here's things you can do. This isn't a take it or leave it all. It's which ones kind of speak to you or make the most sense. You can fit that way. So things like the Calm Companion or coming for surgery workbooks, or things that might be more specific to a team, or things that you need to be prepared to ask your anesthesiologist or the surgeon, because we want to make sure you ask those right questions to the right people. And patients and families have such an interesting mix of knowing themselves best, but also we're the experts on what's coming in. So being able to bring all of those things together, I think have a really good guess of what to throw at the wall and see what sticks.
Yeah, and I think it's a great question, Fiona. And I think your work and the work by the different people in different aspects of perioperative pain, there's probably more to be done. Like, it's always a question of how many resources you can allocate. So if you can identify the patients that have the highest anxiety and then dedicate resources to them early and often, you can probably make the experience a lot better. And I think that we're getting better and better at that. The transitional pain service will do surveys to learn about anxiety and then focus on preoperative anxiety if there's a possibility to do that. We have the ability program and a few other periop programs to treat children with anxiety before they enter the perioperative environment. But often we find on the day is we're sort of navigating it for the first time, or where it hasn't been fully addressed. And this is where people like Caleb, who are so skilled, or the rest of the Child Life team, who are so skilled at navigating, like assessing and managing very quickly to get them into the operating room, because these are a tremendous amount of resources built around this. So.
And I think building in, you talked about identifying the people who have more anxiety, extra kind of spotlighted, but building into this is a hard thing. Anxious is such a fair feeling to come into these situations. We're built in that we can assume people feel anxious when they come in. So we can allocate our extra resources where we need it, because our baseline helps take care of that, foundational amount of nervous that I expect someone to come in. I usually say, are you nervous or worried? Is there something particular? Nervous or is it because you don't do this every day? Yeah. Because we do. So what can we do to help? Because if you have that baseline of, we know we're coming in and we're worried about things, is it something specific, or is it, whoa, this is a big day?
It's overwhelming.
And we build it into our set program, and then that extra resource allocation can go to when we need more than that. And I think that's a way where we can help take care. And I think it will also help staff, because the more it's built in, the more it becomes the norm and the regular, the more comfortable you are as a staff. Because the first time you go have any of these types of conversations, the family's anxious, but so are you. And you have that, like, am I going to say the wrong thing? Am I going to make this worse? I don't want to bring up pain because that's going to freak them out. But then when you get more comfortable, more skilled, more experienced, you really get to shape the experience, like we've been talking with everything else. And then the more you hear from them, the more you get to learn. And that's when you get those extra bits where you're like, I am now bringing that up every time. But that first time, just like it's it's hard for patients and families. So here and being able to work together, I think, can make a huge difference.
Fiona's just put another comment here. Thanks, Caleb, for mentioning Calm Companion. Coming soon, I hear. Totally agree with David. The TPS is awesome. TPS being the transitional pain service is awesome for the most complex surgical patients. Can we clone Caleb?
I think we should name that new robot, Caleb.
There you go.
I actually have a question for the two of you, and would be awesome if any participants within the chat have been in similar situations and have used any particular strategies that they've found effective. But on the acute pain service, we were recently looking after a young teenager who, due to his medical condition, had been admitted about a week before a scheduled surgery was meant to take place because of uncontrolled pain at home. So we were helping to manage pain leading into the surgery. And all along, as we were following this patient, it became very clear that both him and the parents were under the understanding that this surgery was going to fix the pain. So similar to this appendectomy story that you were telling earlier, Caleb, a bit of a situation where communication was challenging with this patient and the parents. And there was probably a degree of gatekeeping that I think the parents were doing, I think coming from a place of trying to protect their son from undue stress and undue anxiety, but became very challenging. All of the teams involved, and I will say there were many, the questioning, like, does this person know that there's going to be a different type of pain after surgery? The medical condition itself might, be rectified and like that might be looked after, but there's going to be a degree of surgical site pain. We actually don't know after the surgery if there's going to be any sort of like post-surgical sort of more internal challenges that we might be dealing with. So I guess my question is, one, how do you sort of approach a situation where parents are trying to protect their child from more information because they're concerned about anxiety and distress in the child? And then I guess the other question, sort of a part two, is when you have so many different care providers and healthcare professionals involved in the care of a person, how do you sort of navigate whose responsibility it is? Is it everyone's responsibility? Should it be one particular person's responsibility to have a conversation about pain expectations? And then how do you make sure everyone's on the same page with the messaging that they're providing?
My first thought when you brought that one up is, like, has someone told them there's no pain after? So where did that expectation start? Was it from a parent not willing, like, who is aware there is pain and discomfort after, not willing to say it, or have they been told?
Yeah. So in an extreme case of this, I think actually when we talk about children, we can sort of work on a gradient, because we don't need to disclose everything to a young child. We can disclose what will help the process as long as the parents understand. As they transition into this teenage age, it actually crosses over into an ethical question about informed consent. And so I've seen, like, the most egregious example is a family that hasn't told their child that they're having a surgery. You're going to go to asleep for an exam, and in the meantime, there's a fairly major surgery that's been planned. In those cases, I think the proceduralist that's performing the procedure has the obligation to fully disclose everything that's going to happen to the patient if they're a competent minor. So that's where I would assign that responsibility. And then we become, if we're not the proceduralist, I'm an anesthesiologist. I'm happy to support them with that conversation, but that's not my responsibility. And I've refused to provide anesthetic until that disclosure was made by the surgical team. So that's sort of the most extreme version of that. But obviously, in a more ideal world, you would have a case conference and explain the concerns, and as a team decide how to bring this to the family, and then maybe choose people within the team who are better at presenting and framing. And so, because that's a skill also. But I think that the proceduralist has to be on board, and then you can build your plan around that. To answer directly to your question,
I think too, sometimes those words that we put in simply can be seen very different. Like, Ashley, you said fix as opposed to help, because help leaves that variance for what pain may come up after, versus fix is seen as a black and white, make better, there you go. And I think even those small changes, I've had times, again, with a patient who's unaware because a caregiver was unwilling to tell them certain things. And then it's almost, how can I make sure that what I say I feel comfortable with, that might avoid a certain word they have, or this type of thing. We're not telling them they're getting a full anesthetic for this because we're not saying a surgery on their arm. Okay, we're going to give you medicine to make you feel more relaxed. And that's where we're starting our first step, because we're going to help with your broken arm. We're going to do this, and you can build from there. And sometimes when you get that hesitation from a parent or family, it's just worried to have that really hard conversation. So taking those steps, but making sure that what you're confident in what you say, and you're going through and seeing if you take those steps, if you're able to build that positive momentum for that type of conversation. My first thought on that one is did somebody tell them that it was going to check mark, it is solved, or is it coming from the patient and family? And when I get asked those questions that I can't give the answer to, is to go find the person who's going to know it best, which is the procedurist. I think it is, I don't know the ins and outs. So you go to the person who's going to know best. And like you said, you'll support those conversations. I will from a child life perspective, but the information has to come from the correct person. And I think it's part of our responsibility as everyone else on the healthcare team is to make sure that you're saying things that are true as well. I don't make promises for things I can't make promises on. So if someone asks me that, you can say, I don't know, as a staff member. I'm not sure. Let's go find out. But we don't want to make those promises that we can't keep, especially with not even your role to make that promise going forward.
You're describing a very complicated, challenging situation. I don't know the case, so I can't comment specifically, and nor probably should I on this sort of public forum, but it's the most complicated situation in terms of pain, right? And actually, I'm sure it can be more nuanced, because you can have a provider who suspects an intervention might treat the pain, but they're not able to offer that intervention. So then you're getting it, and it's sort of like ordering a test, where you're the one ordering the test, you're not the one administering the test, but it's not a test, it's an intervention. So then it really becomes tricky, because are they doing it because primary care provider asked them to provide this intervention, or because they know that this child, based on their indications, need the intervention? So that's where when you ask the question, who should be disclosing, it really becomes tricky.
I mean, I will say, Dave, I think I actually quite like your suggestion, and we've done this before on the acute pain service, where you really actually just have to bring all the key players together to have a conversation about okay, well, what are the expectations here? And then I like the idea as well of having select individuals, perhaps from the most relevant teams, that would then go and approach the adolescent and the family in this state, so that you have representatives from all of the teams that can then convey clear communication, everyone's on the same page, and then they can report back to their teams versus having 20 people in the room, because I've also seen that happen.
And the other trap I've seen is that you have a plan for an intervention, and it's sort of a yes or no to the intervention, but then the planning doesn't continue for what if the intervention does result in more pain, or it actually is very beneficial, but you need a more longer term solution. And that takes more work also, because I think when you can bring forward answers to those questions, the conversation can go easier. So it's not, you might wake up in pain, more pain or new pain than you've had before or not. It's, if you do wake up in more pain, these are the next things that we would do to address it. So there's an outcome that might not be ideal, but we're aware of that outcome and have a mitigation strategy.
And the piece around parents who feel that they're doing the best thing for their child or adolescent and sort of gatekeeping information. Have either of you been in a situation where you've had to sort of reach out to, and this would sort of be an extreme, but bioethics, for example, to sort of bring in a third party who is unbiased, who's able to look at the situation and say, no, in fact, we really should be providing this information to this person?
I haven't personally, but I know of cases, and it can be very helpful. And the other resources that I've had that are helpful are the religious services sometimes, depending on whether the family has especially around blood transfusion, where I've been able to clarify certain specific questions around that. So there are resources that I don't think we have at top of mind when we think of the teams that we have access to that can be really helpful in these tricky situations. And again, sometimes it's a tough question to ask if they have a community member that they could use as a resource to help with decision making, and then these are sensitive topics, but sometimes you can figure out that there is actually another person who, if you include them, makes things a lot easier.
I will just say, because sometimes we do have community partners that are on these sessions. I'm not sure if we have any today, but we also appreciate that here at Sick Kids, we are highly resourced. We do have access to a lot of different specialties and experts who can come and weigh in on these sort of challenging topics, but appreciate that in the community, you don't always have access to these resources, and things can be even more tricky in those situations. On that note about sort of the spiritual care folks. We're very multicultural here. We see people from all sorts of backgrounds. Thinking about a recent case that our team's been involved in where culturally pain is actually seen as something that you should be very stoic about. It's seen as a strength. We see suffering, a lot of us, and can't necessarily, wrap our heads around that. So I wonder, in cases where a family might be not wanting to have a lot of conversations around pain because they actually see it as a strength, and like you actually need to endure pain in order to be, live a full life or be better on the other side or whatever. I wonder if either of you have ever had to sort of change your strategies or adjust them to accommodate a particular cultural belief that might be different than your own.
Not on like grand scales, because again, I'm in blood work, I'm in pre-op. It's like an acute thing is happening a lot more. But I think there's the cultural side of like that stoic, like you're talking about this bigger one. I think it's making sure that the things we're offering, we explain them the best we can. Because if this, we expect this to be a painful thing, it's so hard in short periods of time to have those kind of conversations, but making sure that what we offer is there to explain it, and in mind focused on the child, because I think to me it's different if it's a child versus it's an adult picking. To do the pain on that side is to normalize what we're offering in the situation, maybe showing that the situation is different from daily life. I think, it's different if it's a long-term, you're on inpatient, it's something you're going to go home, it's chronic pain, it's all of those things are different, but that it's at least making sure the option is heard and understood so that it's an informed decision to make. But it's not something I've run into in tons of, to be honest.
Karis just put a question or a comment in the chat about a Mennonite community and their approach to pain with burns. So, it's easy to say I don't know much about the Mennonite traditions, but it would be valuable to find like a religious leader who could comment, and then you could put people in touch with that could speak to them at their level. Like, I suspect that the minimum amount of pain that we could provide after surgery is probably enough suffering for most people to validate whatever pain they were hoping to have. Do you know what I mean? Like, there might be a way to frame it and get an authority to frame it that, don't worry, your child is going through something that even without physical pain, the fact that they need a surgery, they need to recover, is a painful process. So let's get them through this painful process, and they can still meet the expectations of the tradition. But I would imagine finding a religious leader that's agrees and that willing to be in touch with families who are facing this would be a strategy. I provide circumcision services in the community, and I've encountered families that have asked if pain is required as part of a religious obligation during circumcision for people that circumcise. I've actually been able to find religious leaders who are well respected, who are able to say, actually, there's nothing specific about the pain that's important from the religious aspect. And when I transfer that information and I mention the person who gives the information, families actually, they really are happy to hear that and learn that it's not just my professional medical opinion that the pain's unnecessary, but that they have a person that they trust from a religious perspective. I'm sure it's a process to kind of find those people and have community partners that are willing to do that, but that would be my first thought.
And framing the pain management support that you can put forward, not as competing with whatever they're feeling and they're putting in, but saying like they can be in tandem, and trying to toe that line with some nuance between making sure it's not a competitive this or that, but they can come together.
That's a great question. How have you found a way to navigate this?
We have tried to get community partners. There's actually a plastic surgeon in Pennsylvania that is from their community that tries to mediate between their beliefs and sort of, I guess, our beliefs, which are try to minimize pain, right? We want to minimize harm. And in the community, they will do twice daily dressing changes, which are excruciatingly painful. It's been really hard. And there are members, the elders in the community that have asked if they could come here and do their wound care practices in our hospital, which would be twice daily dressing changes with nothing but do it here. And we're like, absolutely not. But we've tried to work with them, and we've had bioethics involved. And unfortunately, in a couple of the cases, CAS had to bring one of the kids in, and it was actually someone in the community that reported this child that had burns that had been open for 10 months, and his arm was fused to his side, and his burns were still not healed. And I mean, he had no function of his arm, no function of his hand, so it was obviously harming the child. So it is really difficult when you have beliefs of adults which are then imposed on the child, but obviously the child's is brought up with those beliefs. However, they're not able to make those choices for themselves. But good outcome. We did establish trust with that family, but we did get, the legal was involved, CAS was involved, bioethics was involved in a couple of the cases.
I think one of the things I've been thinking as we've gone through this presentation is when it's coming up with what do we say, how do we approach it, is to also talk through those alternatives. So if we don't tell someone, if we don't manage the pain, if we don't do it, sometimes it just seems like this thing's hard and it's not what we want to do. So this other alternative will magically be better. So whether it is handling pain, it's telling a kid about something, even on a chronic pain sense, is this intervention might be hard or it might be difficult, but what are the outcomes if we don't do this or if we take this other thing? So there's our plan, what we're putting forward. We talk through that one, but also to give the same respect and the same effort into what these alternatives would look like. And I think that stands true for almost every topic we've talked through today, because it's sometimes we think, and then we'll just, I don't want to be awake for a blood test because it hurts. I'll go to sleep for it without thinking that itself is a tough thing. We're not going to manage the pain because of here, but if we can talk about what these alternatives are and give them their due diligence, I think that's when we can come up with our best plans that fit the huge number of variants and variables we have to take into account when we approach these.
And the other potential avenue is to frame the pain intervention as as preventing a medical outcome. So we're not treating the pain so your child feels better and doesn't have to suffer. It's because pain is associated with chronic pain, anxiety, worse outcomes, avoidance behaviors for ongoing healthcare, which can lead to infection if they're fearful to come back for their, you can say we're not violating your cultural prerogative to avoid the pain. We're actually just achieving a medical prerogative to improve the outcome. I hope within most cultures that I'm aware of, that medical precedence sort of wins most of the time. So maybe to frame it as a medical outcome that you're treating, not just a symptom.
Yeah.
Very hard.
We see some of the most challenging cases here. Fiona, I will pass your comment along to Charis. Caleb, David, thank you so much for your time, for sharing your expertise in some of these patient situations that you've encountered. I think this has been very valuable. I think this has been a very successful National Pain Awareness Week. Hopefully we've brought more awareness to pain, specifically in pediatrics here at Sick Kids.
Thank you for the opportunity, guys.
Thanks, everyone.
It's an honor.
Our pleasure. Thanks, guys. Take care. Bye.